Welcome again, friends, to this teleconferencing session. Today we are discussing the clinical examination of a gynae obstetric cases. In the previous session we have discussed what are the important key points in general physical examination and clinical examination of a obstetric case. So now in this session we are going to discuss important points which you should keep in mind when you are examining a gynae case. So to have with us this session we have the same experts. To my left Professor Kiran Agarwal, and to my right is Professor Uma Goel. So I will request Professor Agarwal to tell our candidates what are the important points which our candidates should keep in mind when they are making a clinical examination of a gynae case. Professor Agarwal, please.
Now we discuss clinical examination of a gynae patient. A gynae patient is slightly different. An OBS patient belongs to a specific age group. Here we may have an adolescent walking to us, a lady from the reproductive age group, or a very old lady in the menopausal age group who may probably need assistance to lie down also. So gynecological examination calls for the highest standard of ethical and professional behavior on the part of the doctor because of a very sensitive nature of the problems which we would be addressing. Respect to the patient and provision of privacy to the patient are of utmost importance. It ultimately leads, this is a key for our success to arrive for the right diagnosis. To make the patient comfortable so that she tells you the history in detail. She may start off with other complaints which are not specific to her problem, and gradually as you make her more comfortable, she opens up and leads you to the right diagnosis. As far as a gynecological examination is concerned, as usual we do a general and a systemic examination, and a gynecological examination which would specifically emphasize on breast examination, abdominal examination and pelvic examination. As far as the general examination is concerned, the consciousness and orientation of the patient need a comment. This patient may be probably being prepared for a surgery, may or may not be. The initial level of consciousness is important. Suppose the patient has a metastasis to the brain. Any neurological disorder would be important. So how well aware of the surroundings the patient is, and also to gauge her general knowledge so as to gauge the history that she is giving us, because now the patients would come and give you everything about the hormonal histories, about the pills that they have taken. A patient who is an oncology patient would tell you about all the chemotherapy drugs. So the orientation of the patient is very important. The build, the nutrition and appearance. A morbidly obese patient would signal an alarm. Is there an endocrinopathy? Is the patient having a thyroid disorder or a Cushing's disease? Does she have menstrual irregularities? Obese patient with slightly hirsute tendencies, just by the patient walks into your OPD or your examination, you think, okay, she might be a polycystic ovarian syndrome. A very lean and thin patient coming to you, an adolescent presenting to you with amenorrhea or menstrual irregularities. Is she eating properly? Is she a case of anorexia nervosa? All these questions ring up just by the appearance of the patient. A jittery patient having tremors, are we missing out hyperthyroidism? A very thin waisted looking patient who's anemic may have an underlying malignancy, tuberculosis. Just the look of the patient would clinch the diagnosis, and one should always think of HIV infections. A short-statured patient presenting to us with a developmental abnormality, a primary amenorrhea, the height is very important. The weight, again, as said in the previous presentation, should be measured and BMI should be calculated. I repeat, a BMI of 20 to 26 is normal, between 26 and 29 is high, and beyond 29 is obese. So a normal BMI is must for a normal endocrinological function, for the normal hypothalamo-pituitary axis to work, and the patient to have a normal menstrual cycle. We all know that diet and attitude modification in the management of PCOS is very important, and they say that even a 5% decrease in weight of the existing values in a patient of PCOS brings about a marked relief in her symptoms. Secondary sexual characters should be assessed. The axilla should be looked for the axillary hair, the development of the breast according to the Tanner's stage. The pubic hair should be commented, especially in a patient who is presenting to you with primary amenorrhea. Pallor again, not only for an obstetric patient but for a gynecological patient, is very important. A housewife coming to us who's been having a polymenorrhagia for past 6 months and is severely anemic, 2-3 gram%, would signify that the lady is really suffering and is having a heavy bleed. But a patient who says that, okay, I've been having heavy periods, but she has a hemoglobin on appearance of around 9 gram to 10 gram%, ultimately tells us that, okay, she may be interpreting it as a heavy bleed, but she is not losing that much amount of blood. A patient of malignancy, an ovarian malignancy, distended abdomen, anemic, wanting to be prepared for surgery, needs a build-up for anemia. Anemia is indicated by pallor of the mucous membranes, tongue, lower palpebral conjunctiva, together with a pale appearance of skin and nails. The presentation of jaundice, mild jaundice. Patient says, I've been having this jaundice since childhood. Does she have a congenital disease like a Gilbert syndrome? 1 or 2 mg%, 2 mg% of bilirubin with evidence of hemolysis? Or she has a secondary sitting there, she's an advanced liver disease. Then jaundice becomes very important. And a missed out diagnosis in a probable patient of surgery of jaundice is going to be catastrophic. So jaundice should be seen in the sclera and in the palate. As far as the oral cavity is concerned, for a gynae patient, teeth, gums and tonsils are very important. Any septic focus should be detected and treated. Loose tooth should be made note of. The patient may be going in for a general anesthesia, and an endotracheal tube is going to cause a disaster. If the patient is wearing dentures, they should be mentioned, and the anesthetist also makes a note of this. This is all necessary for the PSC workup and to make the patient infection free also, because orodental hygiene in our country is generally poor, and this is a part which is neglected. So once the patient has come to us, this part should be looked into properly before she is taken up for any major surgery. Palpation of a thyroid gland is a must. This would indicate a lead to her menorrhagia, her fever, her tachycardia, her jitteriness. So thyroid examination is a must. The lymph nodes should be systemically palpated in the cervical area, the axillars and the inguinal lymph nodes. A special mention of the left supraclavicular gland should be made and palpated, because this is where the secondary would be sitting. Cervical lymph nodes would be there in the tubercular cases. Axillary, is it an extension of a breast CA, or is it a lymph node, or is it infective, or is it a part of lymphoma? So we find that lymphadenopathy can occur in chronic infections like tuberculosis. It may be a part of a metastasis, or it may be a primary disease of the lymphatic system like a lymphoma. As far as the pulse is concerned, it is not just a routine to write that all the peripheral pulses should be palpated. All the peripheral pulses should be palpated. A pulse present in one hand and absent in the other. Are we missing out an aortoarthritis? And suddenly in the post-op we realize that we cannot take the blood pressure from one of the arms, because we've always been examining the patient from one side. So all the peripheral pulses should be palpable. Any irregularity should be noted. Any heart disease should be mentioned, because in the scenario of a surgery, gynae patients, quite a number of them are in the older age group or very old age group also, and they may be hypertensive, and one blood pressure reading is not enough to say whether they are hypertensive or not. Once they are admitted with us, periodic blood pressure recording is a must. Number of times the blood pressure should be recorded to say that what is the basal blood pressure of the patient. And I repeat, temperature should always be taken. The edema of the legs, as in the obstetric patient, in the gynae patient also, edema of legs carries a lot of importance. Bilateral edema may be seen in large abdominal tumors. They are pressing the venous system, the venous return is getting compromised, and there is exudation of fluid leading to bilateral edema. If we find a unilateral non-pitting edema, non-pitting means that there is no fluid, it's a solid edematous swelling. This is highly suggestive of a malignant growth involving the lymphatics. All the patients should also be looked for any evidence of deep vein thrombosis. Any sign of inflammation, redness, any calf tenderness, Homan sign, any swelling should be noted and recorded. Because these patients are chronically ill, they may be having big tumors, and they are more prone to deep vein thrombosis with an added evidence of anemia also. Breast examination is a must. It should be routinely done to detect any breast pathology. A nipple discharge should be noted, whether it is blood stained or infective. Any breast nodule should be mentioned, and if needed should be further investigated by mammography, FNACs, or with surgical consultations. One should realize that breast carcinoma is second to carcinoma cervix in India. Now these three systems, the cardiovascular, the respiratory, and the neurological assessments are very important. The patient should be examined as a whole. Older the age group, the patient may even have coronary artery disease. So a cardiac clearance also, the basic cardiac evaluation of a patient undergoing surgery, let's say for prolapse at the age of 65 years, becomes important. A respiratory examination, these patients with malignancy, they are more prone, they are immunologically down. They would so many times present to us with fever, with cough, with chest infection. Pre-surgery lung exercises should become a must. In fact, the patient should be taught how she is going to act post-operatively. A simple thing like blowing out a balloon should be taught to her. So respiratory exercises and respiratory assessment is a must. Any abnormality, these are very essential because any abnormality found in these systems may modify the surgical procedure, so it should be treated and the risk should be assessed preoperatively and told to the patient. Now after doing all these systemic examinations, when we do an abdominal examination for these patients, again as a rule, the bladder should be empty. The patient should lie flat on the table with thighs slightly flexed and abducted to relax the abdominal muscles. The patient in winters should be covered adequately also over the legs. Now the first look of the patient, and if we find that there is a distension of the abdomen, that is, the abdomen appears to be full. This may occur with tumors, and massive ovarian malignancy may present with an overtly distended abdomen. Ascites, both of them can occur, ovarian malignancy with ascites. It may be a simple gaseous distension arising out of a subacute intestinal obstruction, and even in a gynae patient, one should never forget pregnancy as a differential diagnosis. A very large tumor can cause a cardiorespiratory distress. It's filling up the whole abdomen, the diaphragm is getting pushed up, the patient is having problem in breathing, and at times she's been harboring this malignancy for quite some time and she may present to you only with the breathing problem. For example, a pseudomucinous cyst adenoma of the ovary. Because of the increase in the intra-abdominal pressure, we may notice on inspection, that is, the umbilicus has got everted. This is the gross look of the abdomen. Now the skin over the abdomen should be inspected again for any old surgical scars, any stria, evidence of previous pregnancy, any prominent veins, hepatic diseases, any evidence of inflammation. The patient is harboring an abscess in one corner. It may be an abdominal wall abscess only. That area would be red, inflamed. Any evidence of any infection, any fungal infection, any bacterial infection, scabies should all be noted and preoperatively treated. The movement of the abdominal wall with respiration is very important. It should be noted whether the abdominal wall is moving over the tumor or not. It is restricted whenever there is an evidence of inflammation. This inflammation may be a pelvic inflammatory disease. There we find that if suppose she is having an acute PID, the lower abdomen is not moving that well. The patient is holding back the abdomen. The hernial sites should be examined. An incisional hernia should always be looked for. Now the palpation. The more gentler we are, the more masses we can palpate and more easily we can reach the diagnosis. It should be done with the flat of hand and not by the fingers. First of all, as soon as we touch the patient, we should note any tenderness, any guarding or any rigidity, which would denote an infection, any peritonism, localized or diffuse. Rebound tenderness, that is when we press the hand and release it, and on releasing when the patient experiences more pain, that is rebound tenderness, would indicate a peritoneal irritation and peritonitis. Liver, spleen and kidneys should be systematically palpated. With an ovarian malignancy or a malignancy which is not very obvious, an enlarged liver which is hard or nodular immediately suggests that there is a secondary sitting there. A splenomegaly in a patient with thrombocytopenia which has been missed may signify a hemolytic disease, a tropical malaria or a Kala Azar. The kidneys, the lumbar areas should be palpated for any evidence of any infection. Pyelonephritis should be ruled out and any lump should be ruled out preoperatively only. Now if suppose we find that there is a mass in the lower abdomen, this mass should be examined for its exact location. Where is it exactly located? Is it arising really from the pelvis or it is arising from the abdomen? What is the size of this mass above the pubis? What is the consistency? Is it cystic? Is it firm? Is it hard? Does it have a smooth surface? Can we move it side to side and above to down? How are the margins like? Are they well defined? Are they firm? Or they are not well defined? And the most important thing, is the patient tender over this mass? When we describe the mass like this in so many definitions, immediately the diagnosis is made. Because apart from the gynecological masses, one should always think of masses arising from so many other things. So many times an ovarian mass is confused with a mesenteric mass. So many times an ovarian cyst may be just an encysted tubercular ascites, and at times a mass may be just a full bladder. So the exact definition defining the mass would help. In a tumor arising from the pelvis, a lower border cannot be reached except in ovarian tumors with a long pedicle. Suppose we have a mass which has a long pedicle, then obviously the whole mass is lying in the abdomen and we can reach all around it. That doesn't mean that it cannot be an ovarian mass. Now, as far as the feel is concerned, the myomas feel firm. They will be arising from the uterus. The uterus would not be made separately. The ovarian tumors may feel cystic, and the pregnant uterus is soft to firm. And how to distinguish? If one is aware of intermittent Braxton Hicks contractions, then it is only the uterus, the pregnant uterus, which can have this contraction, and the differential is right there. A full bladder can always be there, but it is tense and tender, and the patient would give us the history of not passing adequate amount of urine. If suppose we find that the patient is extremely tender in the lower abdomen, then what are the possibilities? It can be an ectopic pregnancy. The history would be very suggestive. Amenorrhea, usually there, but may or may not be there. Collapse, evidence of hemoperitoneum or tenderness. Pelvic inflammatory disease, acutely the patient presents to us with fever. She is toxic, signs of infection. The lower abdomen is tender. She may give history of discharge per vaginum and similar episodes in the past. A diagnosis of acute PID can be made. A twisted ovarian cyst, one of the masses, one of the fornix is full and tender. There is a mass sitting there and the patient is wincing, she is in agony, she is vomiting, there is a tachycardia. One should think of an ovarian cyst. A ruptured corpus luteum hematoma. This is not unknown, and you encounter patients once in a while. Patient doesn't have any amenorrhea, the urine pregnancy test is negative, but the patient has signs of tenderness. She has evidence. You put in a needle or do needling, you find blood there, and there is a hemoperitoneum, and she could be a corpus luteum hematoma right in the middle of the menstrual cycle. So these are the differentials of a tender abdomen. Now when we percuss the abdomen, percussion is not a lost art. It should always be done. It helps us at so many places to find out whether it is a gaseous distension or there is a firm mass. Whenever we doing a laparoscopy, it is the percussion over the liver which tells you, okay, the gas is going in the right direction. It is the loss of the liver dullness which tells you that around 300 to 400 ml of gas has gone in. So percussion should be done in all the cases. The pelvic tumor is usually dull with flanks resonant. In ascites, the flanks are dull and one can elicit shifting dullness. We percuss the abdomen, percuss the flanks, we find them dull, turn the patient to one side and percuss again, and you will find that on turning the fluid has shifted and the flanks become resonant. Ascites may be seen in tubercular peritonitis. It may be a part of malignancy. It may be a part of pseudomeigs syndrome. So by shifting dullness we can elicit fluid. Now auscultation also carries a lot of importance. By practice one should know what are the normal bowel sounds. Around 2 to 3 bowel sounds in a minute are normal. Excessive bowel sounds are heard in an intestinal obstruction. We may be having absolutely feeble or absent bowel sounds in a paralytic ileus, which needs urgent attention. Return of bowel sounds after any major surgery in the post-operative is a very welcome sign that the gut has returned back to function. So bowel sounds auscultation is important. A tinkling bowel sounds, more in number, again suggests obstruction. A souffle may be heard in vascular neoplasms, like we heard a uterine souffle in pregnant patients because the uterine blood flow is more to the uterus. Similarly, whenever a blood flow is more to a very vascular tumor, then a bruit or a souffle can be heard, and this can be later on confirmed by an ultrasound or a Doppler examination. Now once we've seen the mass, we made up our mind. Half of the diagnosis is quite clear as far as the abdominal examination is concerned, but the pelvic examination is quite confirmatory and helps us in reaching the diagnosis. It should be a very gently performed examination with a clear-cut interpretation in mind. The bladder should be empty. There should be a female attendant. Consent from the parents should be there to examine a minor. The lower bowels should be preferably empty. Now, what are the essential things which are needed to conduct this examination? A good light source, sterile gloves, a colorless, preferably non-antibiotic prone lubricant, a speculum, and sterile swabs, test tubes, and saline should be available. The facility for taking a pap smear should always be ready whenever we do a gynecological examination. The patient can be examined in 2-3 positions. We can commonly examine the patient in OPD in the dorsal position with knees flexed. This provides a better view of the external genitalia and helps us in doing a better bimanual examination. The patient can always be examined in lateral or Sims position. This is important when we want to detect any lesion on the anterior vaginal wall, because when the patient lies in the lateral position, the vagina fills up with air and the anterior vaginal wall can be seen easily. Patient can always be examined in the lithotomy position. This is generally putting up the legs in the stirrups is at times uncomfortable for the patient. So it is the position of choice for examination under anesthesia in the theatre. We start the pelvic examination with the inspection of the external genitalia. Any abnormality of the pubic hair should be seen. Excessive hair going up till the umbilicus may be a sign of hirsutism. The clitoris, the labia, and the perineum should be examined for any ulcer, for any wart-like growth, any abnormal looking, unhealthy looking mole, any evidence of leukoplakia or vulval disorders, any swellings, any Bartholin cysts, any labial cysts. So all type of problems should be anticipated and the vulva should be carefully examined. Any presence of any discharge, vulvitis, or evidence of blood excoriations should be noted on the vulva. Excoriations present, a saggy moist vulva. The patient is a diabetic. She may be having vulvovaginitis because of candidiasis. Any mass protruding out could be a polyp, and ask the patient to put some pressure. Genital descenses like cystocele, rectocele, uterine descent or prosidentia should be noted. If the patient prior to this examination is complaining of stress incontinence, then once she should be examined with full bladder and stress incontinence should be demonstrated. Being a gynecologist, one should not leave out the rectal area. The hemorrhoids, any evidence of anal fissure or fistula should be noted. She may be having only the rectal warts and we will miss out an HPV infection in this patient. And we believe that HPV is not only at one site. HPV at the rectum, she may be having an HPV problem at the cervix also. So the whole area, the whole perineum including the rectal area should be examined, and stress incontinence should be noted as already mentioned. Now there is a controversy whether we should do a speculum examination before or after the bimanual examination. Ideally one should precede the speculum examination before the bimanual examination, because once we do a pelvic examination it would become difficult to do a pap smear and take the samples of the fluid from the posterior fornix or from the endocervix if we want to take. Now what are the speculums available? We may have a bivalved self-retaining speculum like a Casco's, which is ideal because it is self-retaining. A satisfactory inspection can be done of the cervix. Simultaneously a pap smear can be taken without a help. One can take the secretions from the posterior vaginal fornix, and if needed they should be taken for a hanging drop preparation and a potassium hydroxide mount. Now the other speculum that we keep on using is a Sims speculum. With this we need an anterior vaginal wall retractor. This is better for assessment of the uterine and vaginal wall prolapse because the side walls are not visible clearly. So to assess cystocele, rectocele, enterocele, a SIM speculum is always better. The disadvantage is that at times you need an assistant, and the patient should always be at the end of the table for a SIM speculum examination, which may be difficult at times in a very obese patient or a very old patient. A simple digital pelvic examination done by one finger where we are just palpating. Mind you, we are not doing a bimanual examination. We palpate for any labial swelling, any cyst, abscess. The urethra should be pressed against the pubic symphysis to find out any discharge, which would signify a gonococcal infection, and if this discharge is present, it should be taken up for culture, and if the culture is not available, which is very specific, the Thea-Martin medium for the gonococcal infection, then we should just take it for a gram stain. The vaginal walls should be palpated for any swelling or any abnormality. The cervix is palpated to note the direction, its station. Has it descended or is it at its normal position? It is firm in a non-pregnant state, which is conical and smooth, whereas it may be cylindrical in a parous patient. Cervical motion tenderness is very important, and any bleeding on touch, which may signify a cervicitis or it may signify a malignancy, should be recorded without a miss. Now when we do a bimanual examination for these patients, a gloved right index and middle fingers are introduced in the vagina, and the other hand is kept for the bimanual palpation on the hypogastrium. If the introitus is narrow or the vagina is tender, then one finger may be used instead. First of all, the cervix is commended, and then the uterine outline is defined, followed by examining its size. What is the size of the uterus? Is it multiparous size or big, or is it harboring a fibroid? Then it's commented in the terms of the weeks of pregnancy. The position of the uterus, whether it is anteverted, retroverted, the shape, the consistency, whether it is soft and firm. An experienced examiner can always say whether the uterus is pregnant or not. A pregnant uterus is always very soft to touch to. Mobility of the uterus is very important. Endometriosis or adhesions posteriorly in the pouch of Douglas would restrict the mobility and will cause a fixed retroversion and may be the cause of pain in our patient. After assessing the mobility and the size and everything of the uterus, the adnexa are palpated by keeping the fingers in the lateral fornix and trying to push this fornix up to the hand over the hypogastrium. In between these two hands, we are trying to palpate any abnormal swelling in the tube or in the ovary or in the broad ligament. A normal fallopian tube is normally not palpable. If suppose it is swollen by infection, or if there is a chronic hydrosalpinx sitting there, or there is a tubo-ovarian mass, then definitely this tube would be palpable. The patient may have a chronic ectopic sitting there, which would again be felt as a TO mass. After feeling the fornices, both the lateral fornices, the anterior fornix, the uterus, one should never forget the pouch of Douglas. This should be palpated for any mass, any nodules, tenderness or any collection. The most common swelling which is felt invariably in the pouch of Douglas is a loaded rectum. So a loaded rectum should always be ruled out, and the patient should be asked whether she has been constipated over the period of time or not. A retroverted uterus, the uterus may be felt behind instead of anteriorly in the pouch of Douglas. One may feel prolapsed ovaries or a small ovarian neoplasm which has not become bigger enough to go out into the abdomen. Endometriotic nodules which are tender, especially over the uterosacrals. Inflammatory masses, TO masses which are felt posteriorly. Pelvic abscess, the patient is tender, toxic. We can't find any abdominal abnormality, but there is a pelvic abscess sitting there which may be pointing towards the rectum or the pouch. In a patient of chronic ectopic, we may find a pelvic hematocele. Just putting a needle there and tapping as we do in a PV needling in an ectopic case, we may find blood there in the pelvic hematocele. Now suppose we find a mass on a bimanual examination. We have to define whether it's a uterine mass or it is an adnexal mass. If suppose it's a uterine mass like say fibroid, then the uterus is not felt separate from the mass. The movements of the mass are felt per abdomen and are transmitted to the cervix. That is, if we push the mass from above, we can feel the movement below on the cervix, except in a subserous pedunculated fibroid, where the movements will not be transmitted. If it is an adnexal mass, the uterus is felt separate from the mass. A small uterus would be felt and the mass may be felt sitting on top of the uterus. The movements of the mass are not transmitted to the cervix unless the mass has infected or it is a tumor mass and has become adherent to the uterus. A rectal examination may be done instead of a vaginal examination in children or in virgins, or if the vaginal examination is painful. It should always be done in patient of cancer cervix for palpating the base of the broad ligament or to find out the involvement of rectum. In patients of vaginal atresia, the rectal examination almost gives us quite a lot of information about the pelvis and the broad ligaments. At times, a rectal examination is done to diagnose rectocele. We can do a combined examination, that is the rectovaginal examination, where an index finger is introduced in the vagina and the middle finger in the rectum. This helps us to determine whether the swelling is in the bowel or between the rectum and the vagina. The base of the broad ligament is very easily palpated by a rectovaginal examination. This completes the examination of a gynecological patient. By this time, we are adept in making a provisional diagnosis. This should be supported by certain investigations. Taking off a pap smear is an extension of the clinical examination. The IR spatula, the slide should be ready. And these days it may be taken up in the liquid cytology if available. The endocervical brush should also be ready. Colposcopy if needed. Endometrial biopsy if the patient suits the basic requirements. A transvaginal ultrasonography right there and then in the OPD. Pregnancy test should be done to make the diagnosis, and hormonal assays should be ordered apart from the routine investigations that we do to make a final diagnosis. Thank you.
Well friends, today we have discussed in detail the history and clinical examination of a gynae and obstetric cases. And again I will like to remind you all that unless you practice making presentation to each other and to your consultant at the time of examination, when you are given hardly 40 minutes, you will not be able to cover all. Sometimes it happens that you come to know about the diagnosis in the examination and you tend to ignore your important clinical and history finding from the history and clinical examination when you are making a presentation to the examiner. So please remember that our examiners are not interested in knowing the latest thing or the confirmation of the diagnosis. Their main concern is your approach through history and clinical examination. So if you are careful in keeping into your mind all these points which have been mentioned by the experts, and then you practice them again and again during routine presentation, so I am sure at the time of your final examination you will be able to complete the examination in 40 minutes which is allotted to you. Now I will request Professor Goel, what are the important mistakes the students do, and what are the important negative points, negative finding also which they should mention in the examination, because sometimes the negative findings are also equally important.
I agree with you, Doctor. So that negative points are important, but it depends negative points case to case.
Yes.
Suppose it is a case of ectopic pregnancy, chronic ectopic pregnancy, where patient has forgotten to give a history of amenorrhea, but she has come with a pain in abdomen and irregular infrequent bleeding. So a negative history of amenorrhea which she has not given should be mentioned by the student after making a diagnosis of chronic ectopic pregnancy, which is important. Similarly, in cases of vaginal discharge, if we find it is a candidiasis or fungal infection, a negative diabetic history, which is very important, which is should be taken into consideration, and candidate must make a mention whether she is diabetic or she is not diabetic. And if she is not diabetic, specifically, because that, as you said, time is short, so he has to or she has to summarize the points that related to the case, what are the positive points and what are the negative points. Similarly, if she has got prolapse, history of chronic cough, history of chronic any chronic disease which is putting the abdominal distension, which is putting pressure constantly on the pelvic floor, if it is absent, should be mentioned.
So for the benefit of the students, can you mention what are the important sort of signs or tests in the clinical examination of a gynae and obstetric case which they must not forget?
Yes, as Dr. Kiran Agarwal has already covered most of the tests. Starting from on examination, you have done the examination related to your case. Some are basic investigation and some are
yes,
investigation.
Please, just a minute, please. What is your question? Please ask your question. Please come up. Ask your question from our experts. Yes, please shoot your question.
Hello. How to explain the gynecological diagnosis? First question. And second question is for obstetric purpose.
Yes.
If the patient gives the ultrasonography details or ultrasonography reports are available with her, should we explain their in history?
Okay, thank you. There are two questions. One question is related to the obstetric case. They are asking if they are given some ultrasound reports or some other investigative reports, they are supposed to comment on that, or otherwise should they ask for these reports? Will you like to add in the examination, because it is hardly 40 minutes?
If suppose the ultrasound report is given to them, that means obviously they want you to interpret those reports, and the interpretation should be done, and it should be mentioned while presenting the case that these reports were provided, and this is your interpretation after examining the patient.
I would like to add one more point, that really in obstetrics especially, if you want certain investigation to be done, you ask the whosoever is there that you need these investigation if they are available, so that if the reports are available, will be provided to you so that you can make a final diagnosis. Otherwise, you can present that for further support in your diagnosis, you need these investigations.
Then the other question is, as you mentioned in the obstetric case,
yes,
how they should sort of tell to the examiner the final diagnosis of a gynae case? Say you take an example of a gynae problem, and how they should make a sort of, sometimes the examiner will say, what is your diagnosis?
Suppose you are sure that this is your diagnosis, then you can say, for example, in cases of acute ectopic, usually it is diagnosed. But suppose there is a lump in abdomen and you are not sure, then you have to present like differential diagnosis. First, it is fibromyalgia uterus, or it is ovarian cyst, or it is a pregnancy. Pregnancy has to be ruled out in all circumstances. She may not be giving a history. So you have to give a differential diagnosis. At time in gynae cases, it is difficult to give you a one single diagnosis. You have a liberty to give a differential diagnosis and give positive and negative points for both the cases. For example, if it is a fibromyalgia, you are saying it is a fibromyalgia, then on pelvic examination, is the mass is moving with the cervix? Yes, if it is moving with the cervix, it goes in favor of fibromyalgia. But you are not sure, especially TO masses, tubo-ovarian masses, which are difficult to diagnose. And then you say it can be ovarian cyst, it could be a TO mass. No examiner will detect the marks on diagnosis. But as Dr. has said, that you know the diagnosis and you want to fit all the points in that diagnosis, that is where you fail in justifying your statements. So I will tell you that you please make your own diagnosis. May not, in gynae case, you may not be able to pinpoint the diagnosis. You put up a differential diagnosis, and for each case you give the positive and negative points.
So I hope the query which has been raised by some of the students have been solved. So once again I thank both the experts who have been here, and I am very hopeful that all of you have learned from this interaction. So kindly ask more questions. Our telephone lines and fax lines will be displaying very soon. Our fax number is 011-2953-6134, and our toll-free number is 1800-12345. So we end this session and we'll come back again at 2:30, and this again is going to be a very important session. After lunch 2:30 to 4:30 we are going to discuss important applied aspects of anatomy and physiology in gynae, and what are the important pre-operative and post-operative care which you have to keep in your mind for common obstetrics and gynecological procedures, because in your final examination you also have a ward round. So please do join us at 2:30. So thank you very much for this. Thank you.
Thank you.